Hello, everyone, and welcome to today's webinar presented by the Insurance Collaboration to Save Lives. My name is Valerie Chisholm, and I will be your host today. Lately, I've been hearing a lot of folks suggest that getting more vitamin D can potentially have a huge impact on your health. But is the research really there? Is there scientific evidence supporting these claims? If you, like me, want to see solid published research summarized so a layperson can actually understand it, this is the talk for you. Today's presentation is entitled Vitamin D, What Does the Science Say? Our presenter today is our very own Dr. Kate Hendricks. She has recently retired from 40 years of service, much of which has been spent moving medical research into public health policies and recommendations. Even in retirement, she continues her service to society by volunteering with the Insurance Collaboration to Save Lives, and we are very grateful for her valuable contribution. Before we jump in, let's just talk briefly about logistics. There will be time for Q&A at the end of the presentation. So if you have questions as we go along, please send them in the chat directly to me. So my name is Valerie Chisholm. Please don't send it to everyone, just send it to me. And then at the end, we will address the questions that are sent to me. And now let's welcome Dr. Kate Hendricks.
Thank you, Valerie. Can people hear me okay?
Yep.
Okay. As she said, I'm Dr. Kate Hendricks. Today, I'll be presenting as a member of the Insurance Collaboration to Save Lives. We're a global nonprofit comprising insurance, medical, and public health leaders. We're engaging and empowering global insurance companies to address the problems of excess mortality and morbidity. We are partnering with insurers to screen current policyholders, identify those most at risk of serious health concerns, and attack the problems through intervention, medical care, and lifestyle changes. As many of you may have heard, excess mortality in young adults has remained high through 2023, and disability has reached record levels. We're convinced that people with problems can be identified while they are asymptomatic, before they have a crisis and end up in an emergency department or worse, before they could become the cared for rather than the carers. We expect this screen and intervene approach to reduce mortality and morbidity and to save at least 1 million lives. Our ideas have recently gained a lot of traction within the insurance industry, which is uniquely positioned to offer tools that can make a difference. While the policyholders will reap the benefit in years of productive life, the insurance companies will reap the benefit in cost savings. By reviewing literature and through a pilot study of ICSL, friends, and family, we identified several areas of impact with significant opportunity for improvement. Although I'll touch on these other areas toward the end of my talk, today we're going to focus on vitamin D. The science indicates that getting enough vitamin D can improve health and delay mortality. This slide is an overview of the talk. There's a sizable opportunity for improvement. Studies indicate that a large portion of Americans have levels below the recommended minimum, probably more than half across the board, with extremely high percentages in some populations. After reviewing who is most impacted, we'll talk about risk factors for deficiency. Next, we'll discuss how good vitamin D levels can help your body successfully fight a variety of illnesses, thereby reducing early mortality and improving your quality of life. We'll touch on possible mechanisms of action, and my favorite point in this talk. Low vitamin D is easy to fix. Unlike intense diet and exercise programs, low vitamin D can largely be corrected with inexpensive over-the-counter supplements. I'll be presenting a layman-level overview of the research supporting these statements. Although there are thousands of studies on the topic, we're highlighting just a few dozen. Before I start talking about vitamin D, I'll provide a little background about myself. I graduated from University of Illinois College of Medicine in the early 80s and Tulane School of Public Health and Tropical Medicine a few years later. I finished my training as an Epidemic Intelligence Service Officer with the Centers for Disease Control. I'm board certified in preventive medicine and have more than 3 decades of public health experience, starting as a generalist with the state health department and ending as an anthrax expert for the CDC. You can find me on ResearchGate, which here documents my more than 100 publications, which have been cited over 6,000 times by other scientists. It's safe to say that reviewing research to identify the best course of action is my sweet spot. Today, we'll review data from several dozen studies. The references are provided on each slide. If you look them up, you'll find that many are review papers. Some are systematic reviews, and a number of the interventional studies that are described are randomized controlled trials, which are considered a very high quality type of trial. I want to thank Valerie Chisholm, an actuary with Everence, for many helpful edits to this talk. And I want to point out that the opinions expressed in this talk are my personal opinions. Okay, let's dive in. There are three sources of vitamin D. You can consume it, you can take a supplement, or your body can make D3. To do this, you'll need skin, UV radiation from the sun, and a cholesterol precursor. Both D3 and D2 enter the metabolic pathway here. D3 is then converted in the liver to the form that is measured in your blood when you ask your doctor to check your vitamin D level. Now, this looks like it's going slowly because it does go slowly. This is a slow metabolic step. The blood form is converted to the hormonal form. That's right, the hormonal form in the kidneys. D3 comes from animal-based foods and is the generally preferred form of vitamin D supplement. D2 comes from plants and also from fortified foods. Dairy products and milk substitutes such as soy or almond milk or formula are usually fortified with 100 to 150 units per 8-ounce cup. The body's ability to synthesize vitamin D varies based on many factors. We're going to focus on some of the more important ones: latitude, month, skin type, and age. How far north or south you live determines how easy it is for you to synthesize vitamin D. These data are for some people with light skin types. For different skin types, the graphic would be somewhat different. People who live near the equator are in zone 1. They have the easiest time making vitamin D. People who live in the lightly stippled area, which includes most of the continental US, are in zone 2. They can't make enough vitamin D at least 1 month of the year. People in zone 3 have a hard time making it year-round. Vitamin D synthesis also varies by month. Let's go ahead and focus in on just the US. These colored maps show how easy or hard it is to synthesize vitamin D by month and geographic location. The left blue-green end, starting with 0, is the unlikely end for synthesis, and the dark magenta-purple end, ending at 11, is the likely end for synthesis. In the continental US, June, July, and August are our best months. If you're lucky enough to live in Hawaii, you can make vitamin D year-round. A rule of thumb: if your shadow is longer than your height, you're not getting enough UV radiation to make vitamin D. This is one of the more complicated slides we're going to look at. So far, we've talked about skin type, latitude, and season. So now let's discuss how these three factors work together to impact vitamin D synthesis. There are 6 Fitzpatrick skin types, ranging from type 1 to type 6. Someone with type 1 would have very pale skin, usually with red or light blonde hair, and someone with type 6 would have very dark to black skin and hair and brown eyes. These groups synthesize D at very different rates. I'm a type 3. At noon in Miami, with my skin type, with a quarter of my skin exposed, face, neck, and arms, it would take me 6 minutes to synthesize 1,000 units of D in the summer and 15 minutes in the winter. If I were eating an outdoor lunch with someone with skin type 5, it would take her 12 minutes in the summer and 29 minutes in the winter to make 1,000 units of vitamin D. If my friend and I flew to Boston in the summer and went outdoors at noon, it would take us just a little bit longer to synthesize 1,000 units of D, 7 and 13 minutes. However, at noon in winter, I would need an hour to synthesize 1,000 units, and I'd get very cold because I wouldn't be having a coat on, and my friend would be out of luck. as it would be impossible for someone with her skin type to synthesize 1,000 units of D at that time of day, at that latitude and season. Okay, this one's not good news. Now you can add vitamin D production and efficacy to the list of things that change with age, and they don't get better. So if you take this doctor, he's 20 years old on the left, 50, and then he's 80. Aging reduces the 7-dehydrocholesterol in his skin. Ever notice how your skin gets drier as you age? Aging reduces his skin's production of vitamin D. It reduces his kidney production of the active hormone, and it reduces the amount of vitamin D receptor around. If vitamin D is the key, then you can think of the receptor as the lock. Okay, there's even more that happens as you age, but that's all we have time for today on that topic. Vitamin D levels vary based on race, occupation, living conditions, and diet. A level of 30 nanograms per mil of 25-hydroxy vitamin D has often been used as a cut point for discussions about deficiency. Some groups have used 20 rather than 30. However, regardless of which group is making the recommendation in the past, adequacy has focused on bone health. As data have become more available on the wider impacts of vitamin D, a number of experts have promoted levels of 50 or more. So some shorthand we're going to be using during the talk. When vitamin D is measured in your blood, it is 25-hydroxy vitamin D levels that are measured, but I'm just going to say vitamin D levels. If I say a level of 30, I mean 30 nanograms per mil. Finally, to help with orientation, I've added a red line at 30 nanograms per mil to a number of graphs. As I mentioned a few slides ago, vitamin D conversion is affected by skin type or pigmentation. Darker skin types take more sun exposure to achieve the same levels. Although every person has multiple factors that impact their D levels, Blacks and Hispanics generally have dramatically lower vitamin D levels than whites. This is true in the general population. During 2011 through 14% of whites, 32% of Hispanics, and 53% of Blacks had levels below 20. Although this study uses 20 rather than 30 as a cut point, I've included it because the sample was sized to represent everybody in the whole US. The next slide, based on an earlier iteration of the same data set, uses 30 as a cut point, and many more people fall below 30 than 20. At the time of this survey focused on pregnant females, 54% of white, 83% of Hispanic, and 95% of Black pregnant females had levels below 30. Vitamin D deficiency and racial disparities begin well before adulthood. This slide shows that both Black male and female adolescents in the state of Georgia, where I happen to live, had average levels below 30 all year, and that white male and female adolescents fell to an average of just 30 in winter, you know, cold and flu season. Now let's look at occupation. In a review of 71 studies measuring vitamin D levels for various occupations, insufficient vitamin D levels were found in 67 to 95% of the occupations shown here. Surprisingly, 75% of outdoor workers, people who might be expected to have the most sun exposure, had low levels. This is probably because most outdoor workers have little exposed skin. So if you're wondering whether someone like a lifeguard would have better levels of vitamin D, the answer is yes. Most, but not all lifeguards in a California study had levels over 30, and 69% had levels that exceeded 40. Although people think athletes are the epitome of health, elite athletes often have low levels of vitamin D. In the 3 studies summarized on this slide, levels below 30 were noted in 3/4 of college athletes invited to try out for the NBA, 2/3 of male and female Italian alpine skiers, and a little over 40% of trainees at a soccer school in Moscow. I'm sorry I couldn't fit the references on these slides, however, they are available on request. Institutional living is a risk in this prison system in Massachusetts, Average levels for both Black and white offenders who were not taking supplements were way below 30. However, Black offenders had far lower levels than whites, and this was particularly marked in the winter and spring. What you eat affects your vitamin D levels. Diet significantly affected D levels in this cohort of European adults. People who ate meat had the highest levels of vitamin D. Those who ate fish had the next highest levels, and vegetarians and vegans had the lowest levels. Notice that the dietary differences persisted throughout the seasons. Not surprisingly, people who can't eat or drink dairy products, which are often fortified, have lower vitamin D intakes and lower levels. This study found that people who were lactose tolerant, who could consume dairy products, had average levels of 30 versus 25 for the lactose intolerant or non-dairy consuming group. This was highly statistically significant. Now that we've gone over how you make vitamin D and what factors affect levels, and that deficiency is very common, let's look at how that can impact your health. The next 3 slides are from a 2021 review paper that summarized hundreds of vitamin D studies. So if you want to pick up just one study, this might be a very good one to get and read. Some studies compared high to low levels. Some evaluated supplementation, and some, like the one in the middle, did both. High versus low levels are associated with lower all-cause mortality, in other words, longer lifespans, and decreased risk for Alzheimer's disease, colorectal cancer, which is the 3rd most common cancer in both men and women in the US, and it also decreases it also is associated with decreased risk for multiple sclerosis. Supplementation, decreased risk for multiple sclerosis, diabetes in people who are pre-diabetic, serious asthma, and respiratory infections, including SARS-CoV-2. Okay, this is also from the same paper. Let's look at several pregnancy-related outcomes examined in this review. Many of the papers described are actually systematic reviews that synthesize data from many studies. As you probably know, randomized controlled trials are often viewed as a very high quality type of trial. In these first 3 rows that summarize data from randomized controlled trials that included thousands of pregnant women as subjects, supplementation during pregnancy decreased risk for preeclampsia, low birth weight, and prematurity. In these studies, vitamin D supplementation was in addition to the 400 units found in most prenatal vitamins. Take a look at the impressive amount of risk reduction from 28 to 63% reduced risk. In a review summarizing 25 observational studies, pregnant women with high versus low levels of vitamin D had children with decreased risk for attention deficit hyperactivity disorder and autism trait. Finally, in a single observational study, high versus low levels of vitamin D were associated with decreased risk for C-section. Recall from an earlier slide that in the US population, 50 to 95% of pregnant women had vitamin D levels under 30. Think how much maternity outcomes could be improved with something as simple as vitamin D supplementation. Good levels are associated with decreased all-cause mortality. 28 biomarkers were assessed longitudinally in a cohort of almost 270,000 UK adults to see which of them could predict all-cause mortality. During the 12+ years of follow-up, there were about 15,000 deaths. 4 biomarkers, cystatin C, which is a renal biomarker, C-reactive protein, vitamin D, and hemoglobin A1C were the best predictors of all-cause mortality for both men and women. They actually predicted mortality better than smoking, obesity, hypertension, and inactivity. In fact, the group with the best D levels had 13 to 16% lower mortality than the group with the lowest levels. This is why our insurance collaboration feels vitamin D can help us save 1 million lives. Good vitamin D levels decrease risk for dementia. In this study, a little under 430,000 UK adults with no previous history of dementia or stroke were enrolled and had vitamin D levels performed. During follow-up, there were 3,400 new cases of dementia and 5,300 new strokes. Severe vitamin D deficiency at baseline increased risk for dementia by 80% and for stroke by 40%. These authors feel that 17% of dementia could be prevented by increasing D levels to just 20. If each of these seniors with a memory problem represents a little under 1.2 of the 7 million people in the US estimated to have memory problems in 2020, this would be a 17% reduction, almost 1.2 million people. Here's a very recent study out of Canada. Of 12,000 Canadian seniors who started out without dementia and who were followed about a decade, those who were on vitamin D supplements were 40% less likely to develop dementia than those not on supplements. This was true even after statistically adjusting for age, sex, education, race, cognitive diagnosis, depression, and a genetic risk factor for dementia. Here's a graph showing the differences in cognition over time with the blue supplemented group on top and the green unsupplemented group on the bottom. Vitamin D supplementation broadly reduces the risk for respiratory infections. In a 2017 review summarizing 25 randomized trials with over 11,000 participants, vitamin D supplementation decreased risk for respiratory infections by 12% overall and by 70% in persons whose vitamin D levels were very low, less than 10 nanograms per mil. It decreased risk for respiratory infections in persons receiving daily or weekly supplementation, but not in people who received a one-time high dose. Okay, now let's take a look at the respiratory virus that's recently upended society, SARS-CoV-2, and the disease it causes, COVID-19. Good vitamin D levels help you resist SARS-CoV-2 infection. These study authors analyzed 190,000 patients who were tested for SARS-CoV-2 during mid-2020, who also had at least one vitamin D level checked during the previous 12 months. Patients with lower levels, I should say, less than 20, had the highest positivity rate, 12.5%. Those with intermediate levels of 30 to 34 had intermediate positivity. And those with even higher levels over here on the right, more than 55 nanograms, were least likely to be positive for SARS-CoV-2, 5.9%. After adjusting for risk factors in a statistical model, they concluded that SARS-CoV-2 positivity is strongly and inversely associated with circulating D levels, regardless of latitude, race, ethnicity, gender, or age. This is the study that I used to decide what levels were optimum for myself and my family. The prior observational study compared recent vitamin D levels to SARS-CoV-2 positivity. This next study was a double-blind randomized controlled trial that assessed whether SARS-CoV-2 infections could be reduced through supplementation. It was conducted in healthcare workers in Mexico City during the last half of 2020. The 321 enrollees tested negative for SARS-CoV-2 by PCR at the beginning of the study. They were then provided with either 4,000 units of vitamin D or placebo for just a month to take each day. Symptomatic workers were assessed for SARS-CoV-2 by PCR over the next 6 months. Follow-up was completed in just under 100 in each arm, in the placebo and the vitamin D arm of the study. No adverse events were noted in either arm. The SARS-CoV-2 infection rate was far lower in the vitamin D group than in the placebo group, 6.4% versus 24.5%, which is highly statistically significant. This effect was independent of whether the worker was vitamin D deficient at the beginning of the study. So far, we've looked at the impact of vitamin D on resistance to infection. So here are two studies looking at the impact of D on illness severity in people who have already gotten infected. This Spanish study was performed in 2020, so very early. It included 76 consecutive patients hospitalized for radiographically confirmed viral pneumonia who were positive for SARS-CoV-2 by PCR. The 76 patients were randomized 1-2 to either standard care or standard care plus vitamin D, which in this case was calcifediol, the version that has already been metabolized in the liver. ICU admissions were 98% lower in the vitamin D group than the placebo group, shown in red. Actually, yeah, on the bottom, half went to the ICU. There were 2 deaths in the placebo group and none in the vitamin D group. In this study, frail French nursing home residents received 80,000 units of vitamin D3 every 2 to 3 months. Of 66 patients who were SARS-CoV-2 positive, survival rates depended on whether the resident had their most recent when they had their most recent dose of vitamin D. Survival rates were 82% for the 57 residents who had received D3 in the month before or during their first week of diagnosis, versus 44% for the 9 who had not received D3 in the past month. That is also highly statistically significant. Now, if you want to know the current status of studies on vitamin D and SARS-CoV-2, go to vdmeta.com, which is updated as new studies are published. When I recently checked last week, it had summary data for 120 studies that included more than 195,000 patients. Dots on the blue side show results of studies for which supplementation produced a positive effect, and those on the red side, on the right, show the results of studies for which supplementation produced a negative effect. The vertical bars show the statistical average of all the studies. Overall, vitamin D decreased risk by 60% when given early for treatment, 44% when given late for treatment, and 31% when given as prophylaxis before infection. Good vitamin D levels would improve health equity. Compared to whites, Black Americans are 15 to 20 times more likely to have severe vitamin D deficiency. They also have higher incidence of and mortality from many health-related problems, particularly pregnancy outcomes. While many factors undoubtedly contribute to this disparity, severe vitamin D deficiency in Blacks, which is easily remediable, clearly contributes to these inequities. There's a lot of lip service paid to redressing disparities in health outcomes in minority populations, but I find it difficult to take any entity seriously that overlooks something that is so easily remediable. So far, we've seen study after study showing that good vitamin D levels are associated with better outcomes in lots of diseases. So let's take a look at a few possible reasons for this. Here you have 2 generic cells. These could be in your intestine, your liver, or part of your blood-brain barrier. Vitamin D affects physical barriers such as the tight junctions, adherence junctions, and gap junctions between cells. You can think of these various junctions as mortar that holds bricks together. For instance, maintaining proper cell junctions in your intestines reduces leakiness, making it harder for foreign substances such as germs and allergens to get into your bloodstream and travel around your body. Your immune system is generally divided into 2 components: innate immunity, which you start off with, and acquired immunity, which you acquire. Most white cells have vitamin D receptors, and it has a significant impact on both components of your immune system. On the innate side, vitamin D promotes the production of various antimicrobial peptides, and it decreases the expression of inflammatory cytokines, which are chemicals that are used for intercellular communication. On the acquired side, vitamin D changes the type of T lymphocytes, usually away from inflammatory types. And it helps B lymphocytes to switch antibody class. Physiologically, inflammation is usually not helpful. Occasionally it might be, but usually no. And most chronic diseases have a significant inflammatory component. When looking at metabolic pathways, you can think of them like highways. If one pathway is blocked, the metabolites, chemicals, are going to get detoured. Normally, angiotensin converting enzyme, which is there in the middle in green, angiotensin converting enzyme 2, ACE2, promotes the conversion of angiotensin 2 to angiotensin 1,7 down on the bottom. So it promotes things going to the left on the slide. Okay, spike protein from SARS-CoV-2 binds to and blocks the ACE2 receptor, which has an overall inflammatory effect. It drives things to the right. The active metabolite of D3 minimizes the negative effect of SARS-CoV-2 on this metabolic pathway in a couple of ways. First, it inhibits renin expression. This slows down this pathway shown on the right. And second, it stimulates ACE2 receptor expression, thereby speeding up the pathway going to the left. This has an overall effect of countering inflammation and protecting tissue. Vitamin D appears to have some generic antiviral properties. In a test tube experiment, it decreased replication of human immunodeficiency virus, HIV. In another test tube experiment, it made cells more resistant to dengue infection. They produced fewer pro-inflammatory chemicals and more anti-inflammatory chemicals. Finally, in live pigs, it decreased intestinal damage from rotavirus. Thus, higher vitamin D levels appear to improve at least some response to a variety of viruses. Hopefully, by now you're convinced that vitamin D can have a significant effect on improving your health, both near and long term. You've seen that many groups are likely to have low vitamin D levels, including people living in the northern half of the US, people with darker skin types, and anyone who works indoors. I would encourage everyone to get tested to see what your current level is. So how can you do this? You have quite a few ways you can determine your vitamin D level. You could ask your doctor at your next appointment, or if you'd like to get your baseline results sooner, you can try some of the options presented here. Quest, LabCorp, walk-in lab, Ulta Labs. There are even some home-based options that are done through finger sticks here on the right. So is a vitamin D level the only way to find health problems early? No. Although this talk is focused on vitamin D, there are other inexpensive blood tests, also called biomarkers, that can identify problems before you develop symptoms. By reviewing literature and through a pilot study of friends and family, we identified several areas of impact with significant opportunity for improvement. This slide shows the biomarkers which we think have the highest payoff. Biomarkers that can identify asymptomatic people at risk for cardiac events and stroke, with common nutrient deficiencies, at risk for metabolic diseases, and with long-term impacts from COVID-19 and related issues. By getting screened, it would enable people with new abnormal findings to seek triage and counseling. Early intervention should decrease acute fatal cardiac and neurologic events and also decrease gradually disabling cardiorenal, metabolic, and neurologic events. And how would you access these biomarkers? You could, the same way as before. You could ask your primary care doctor to screen you. You could get tested through Quest, LabCorp, walk-in labs, or Ulta in most states. And pretty soon ICSL will have some testing links on our website. Or you could also consult with some of the alternative providers who are shown here. Whether you get tested or not, it should be obvious that a large percentage of us will benefit from supplementation. So let's look at how much we need. What is the effect of different strengths? Recall from our slide on vitamin D metabolism that it takes the liver a good while to turn D3 into the blood form, actually weeks. So popping a bunch of D3 when you have a cold may or may not help you with your current cold. This is likely why researchers in Brazil and Spain found different effects of vitamin D when given to patients hospitalized for COVID-19. The Brazilians gave a one-time high dose of something that would take weeks to work, the pre-liver metabolized form, and the Spanish gave repeated doses of a metabolite that takes just hours to work, post-liver metabolized form. So let's take a look at 3 studies comparing intake to blood levels. In the first study, Korean Taekwondo athletes who had low levels were randomly assigned to either 5,000 units a day or placebo for 4 weeks. At the end of 4 weeks, all the supplemented group and none of the placebo group had made it to 30. However, do note a 2-fold variance in the response to 5,000 units a day over the course of just a month. Here's a supplementation study performed in nursing home residents who we would expect to be much less healthy than the previous group. This study was done over a 4-month rather than 4-week period. In this study, nursing home residents were assigned to one of 4 supplementation groups, 800 units, twice the amount in most multivitamins, 2,000 or 4,000 units per day, or 50,000 units per week. At the end of the intervention, only the 50,000 units per week, or about 7,000 units a day, raised the blood levels for all the nursing home residents. Most elderly people required more than 10 times what comes in a multivitamin to reach a level of just 30. But again, note that there's a lot of inter-individual variation. So there's not a simple answer that's right for everyone. We encourage people to get tested. Then if they're low, they should start a supplementation routine. Ideally, they would retest in a few months. In this final rather complex slide prepared by Grassroots Health, daily intake is plotted against vitamin D level. Each of the 7,000 participants is represented by a gray dot. Grassroots Health suggests everyone should attain a level of 40 to 60, and that is shown in the green horizontal band. I've also put a red line at 30. It appears that 4,000 units per day puts a majority of people above 30, and many fall within the 40 to 60 range. However, even at this intake, you have a handful of people whose levels are still under 30 and some over 100. This slide demonstrates that ideally someone, again, should get tested before starting supplementation and then retest a few months later. Now, let's take a moment to discuss whether to take vitamin D by itself or with K2. Vitamin K is a fat-soluble vitamin that occurs in 2 forms, K1 and K2. Both are important for blood clotting. K2 also helps regulate calcium balance and maintain skeletal and heart health. Adding K2 to D3 helps maintain bone density by pulling calcium into the bone. The MK7 form of K2 is particularly good for this. So adding K2 to D3 also helps reduce fracture risk, and it keeps calcium deposits from forming in arteries. So the answer is D3 should generally be taken with K2. Vitamin D supplements are inexpensive. This is not an endorsement of any brand. They're just shown for illustrative purposes. You can see that a daily dose of 5,000 units of D3 with 100 micrograms of K2 would range from 5 to 12 cents a day. Okay, a word about toxicity. A level over 200 nanograms per mil is considered toxic. It's hard to get a blood level this high if you are taking a normal dose. In fact, the most common causes of toxicity are manufacturing errors that result in intakes that are hundreds to thousands of times more than what is labeled. However, misadministration may also be involved. Toxicity symptoms include nausea, vomiting, fatigue, weight loss, constipation, and sometimes kidney stones, and calcium levels can be increased. People with the few so who should check with their doctor before supplementing with D3 or K2? For D3, the answer is people with sarcoidosis, who could become hypercalcemic when taking supplemental D3. And for K2, the answer is anybody who is on a warfarin type blood thinner, as that normally works by interfering with vitamin K. Okay, so what does the science tell us? We've seen how common low vitamin D levels are in the US, Levels are low for at least half of whites, 80% of Hispanics, and 90+% of Blacks. Everyone in the continental US, even people living in South Florida and Texas, have difficulty synthesizing vitamin D during the dark days of winter. The only occupation that makes it likely that you would get enough vitamin D is lifeguarding, and some types of diets, those lacking dairy and meat, put you at risk for low levels. Having good vitamin D levels can improve your long-term health by reducing risk for dementia, stroke, and all-cause mortality. Good levels can also improve near-term health. This is particularly true for babies and mothers. Good levels also decrease your risk for respiratory illnesses, including COVID-19. Finally, low vitamin D is easy to fix. Most people with low levels need supplements to reach higher levels. However, how each person responds to additional sun and supplements will be different. I personally take about 5,000 units 5 times a week. Don't be fooled into thinking your multivitamin will be sufficient. Find out through testing whether your level is low and also how supplementation works for you. Remember that daily and weekly doses both work, but monthly doses don't work very well. Also, because it takes the liver a good while to turn D3 into the blood form, it will take you at least a month to build up to a good level. Almost everyone I speak with has someone in their personal orbit who has died suddenly or recently developed a major health issue. But you can reduce these risks. You can check your vitamin D, make sure it's in a good range, eat right, exercise, go to your doctor and request the other tests that we mentioned. And when you get your results, you can either take a breath of relief or have a plan for reducing your risk. You can also encourage your family and friends to do the same. Not everyone's aware of the recent sizable increases in death and disability, particularly in working age people, so they may not take any of these measures. At ICSL, our goal is to save at least 1 million lives. We're partnering with global insurers who are uniquely positioned to make a difference. By screening and intervening, insurers can help policyholders live longer, healthier lives. They can also improve their bottom line as they do best financially when their insureds lived full, healthy lives. In short, insurers can do well by doing good. Please join us.